Welcome, and thank you for joining the American Heart Association for this educational webinar for healthcare professionals titled Contemporary Treatment of SVT. This is the second webinar in a three-part series. As part of our Supraventricular Tachycardia initiative, these activities are supported by Milestone Pharmaceuticals. It is important to note that all program material was developed independently. The views and opinions are our own and reflect the synthesis of science. Content should not be considered as the official policy of the American Heart Association. I am Dr. Cicely Dye, and I will be your moderator today. I'm director of the EP Lab at Naval Medical Center, San Diego. For this discussion, we are joined by Dr. James Eep and Bradley Knight. Dr. Knight.
Pleasure to be here. Thank you.
Thank you very much for allowing me to participate. Sorry, my video took a while to pop up, but I'm excited to be part of this program. Thank you.
All right, and Dardeep.
Again, thank you for this opportunity. It's a pleasure to be here. I'm from Weill Cornell Medicine in New York City.
Right. Presenter disclosures are shown here. After the presentation, we will have a question and answer session to answer your questions. Please take this moment to open the Q&A feature in the toolbar of your Zoom screen. Throughout the program, just enter your questions in this Q&A feature, and we will answer them after the presentation as time permits. The learning objectives are understand acute treatment of supraventricular tachycardia and to identify chronic treatment options for supraventricular tachycardia. SVT is actually very prevalent. It affects 1 in 300 people in the United States. The prevalence is slightly higher in women, but it happens against all age groups. As you look below, you can see the age ranges and you can see the patients that it impacts. Next slide. So we're going to start off with our case presentation. We had an 18-year-old otherwise healthy male present to emergency room for chest pain and palpitations after exercise. During exercise, he noticed he had an abrupt change in his heart rate, and he also has his chest discomfort and lightheadedness during that time. He had decided to stop exercising, and then he presented to evaluation where he was found to have a heart rate in the 200s. And this is a presenting EKG. Next slide, please. He's had very similar presentations in the past. He's noticed them in middle school and for about every couple of months since then. They always are abrupt in onset and they are typically associated with exertion. He has had some associated lightheadedness with these episodes, but he has no history of syncope, no history of heart disease in the family, and no family history of sudden cardiac death. Next slide, please. This is his presenting EKG. As you notice, the patient has a narrow complex tachycardia. We would probably describe this as a short RP tachycardia because you can't quite see the P waves. Next slide. So Dr. E, can you tell me a little bit about how you would treat these patients if you came into the emergency room?
Sure, yeah, I'm happy to discuss that. When anyone presents to the emergency room, it's very important to have a quick understanding of the diagnosis, which you mentioned is a short RP tachycardia. And the key thing in beginning to understand for patients who have an SVT, it can be immediately terminated with a vagal maneuver, which we'll be discussing in a moment. There are various vagal maneuvers, such as a Valsalva maneuver or carotid sinus massage. And if that's not effective, then if adenosine is readily available, intravenous access can provide this medication that quickly slows down conduction through the AV node to terminate an SVT. Most of the time is AV nodal dependent. We're talking AV NRT or AV node reentrant tachycardia on the left side, or orthodromic AV reciprocating tachycardia on the right side, involving an accessory pathway. If patients are continuing to have SVT despite use of these vagal maneuvers or adenosine, then it's important to understand if the patient is hemodynamically stable or unstable. Because hemodynamically unstable patients with hypotension should be immediately cardioverted with synchronized cardioversion. For patients who are hemodynamically stable, then depending on whether a patient has pre-existing accessory pathway conduction with the delta wave or not, then other AV nodal blockers such as beta blockers or calcium channel blockers can be given intravenously to terminate the rhythm.
Thank you for that explanation. So our patient, as you can see on the next slide, he was given vagal maneuvers and he terminated and went into sinus rhythm. Dr. Eve, can you talk to us a little bit about vagal maneuvers?
Sure, yeah. So different vagal maneuvers are available, can be easily given, well, at least facilitated by a medical provider, or patients can do this on their own. I often teach patients the importance of using Valsalva maneuvers, which the objective is to increase intrathoracic pressure by bearing down against the closed glottis for 10 to 30 seconds. This can send a temporary nerve input or to the AV node, slowing conduction, as we discussed, to terminate an episode. Sometimes these maneuvers are not effective, in which case we may do carotid massage. Of course, it's important to listen for carotid bruit to make sure we're not disrupting any plaque from a carotid artery stenosis. This can be applied with steady pressure for 5 to 10 seconds. Those other vagal type of maneuvers are trying to elicit a diving reflex with ice cold water on the face. And if these, there have been several studies that have looked at the use of these maneuvers, these non-invasive maneuvers for acute treatment of SVT. And overall, the conversion rate is about 27%, as you can see in this study that was published a number of years ago. If Valsalva didn't work, some patients were able to terminate with carotid sinus massage. And if patients were started with carotid sinus massage, only 10% converted, then the rest of them, or not, some of them also converted with Valsalva. But again, the combined success is only about 28%. There was another study looking at how to improve the effectiveness of a Valsalva maneuver. And this was published in Lancet about a decade ago. Patients who performed a Valsalva maneuver followed by a passive leg raise immediately after Valsalva strain was able to increase the effectiveness of a standard Valsalva maneuver. Sometimes people think about whether or not if acute management using these maneuvers is not effective, can we give patients a pill? Since intravenous medication is only available through paramedics or in the emergency room, can we give patients a pill to swallow to self-treat SVT? And the data behind this is actually not that robust. Many of these studies were done, or a couple of these, there's only 2 actually, that were done decades ago in small numbers of patients. This was one of the studies published in Circulation in the 1980s of a cohort of 15 patients with SVT. They were given either a placebo or a combination of crushed diltiazem and propranolol to increase the bioavailability of the medication. And of the patients given the diltiazem propranolol combination, 14 were able to convert. However, 4 patients developed orthostatic dizziness. One patient had second-degree AV block transiently. Another one had junctional bradycardia. So this approach to treating patients with a pill-in-the-pocket strategy may not be very safe. There was another study published by a group in Italy, again published in JACC about 2 decades ago. Patients with SVT were given a pill in the pocket, either placebo, flecainide, or the combination diltiazem propranolol, and wanted to assess in 33 patients who were given this combination, how effective was this regimen. Although some patients did convert with these pill in the pocket approach in an observed setting. A couple of them did have some adverse events. A couple of patients had hypotension after giving the drug and had to be cardioverted while they were in the hospital. Other patients following SVT interruption had sinus bradycardia below 50. And so even of this cohort of 33 patients, they selected patients who had the highest conversion rates, whether it be propranolol and diltiazem or flecainide, follow them as an outpatient. Of these 26 patients, 19% of them still had failure of conversion of their SVT, and one patient developed syncope and trauma after a diltiazem propranolol combination. This is the reason why I think the ACC-AHA Heart Rhythm Society revised their guidelines from the initial 2003 recommendation of treating SVT with pill in the pocket from a class 1, downgrading it to a class 2B in the 2015 recommended guidelines. The European Society of Cardiology also modified their guidelines for treating SVT. We talk about the use of chronic medications, AV nodal blockers such as calcium channel blockers, Etripamil, diltiazem, or beta blockers. That is reasonable as a class 2A recommendation, but the use of pill in the pocket was actually not mentioned in the latest 2019 guidelines. Use of flecainide, propafenone is rated as a 2B recommendation, and beta blockers as a class 2A recommendation. This brings us to another topic, which is the use of, can we develop a drug that is able to provide relief of patients, for patients with SVT in an acute setting? The drug would have to act quickly and perhaps not last as long as some of the oral medications that were evaluated in this pill in the pocket approach. And this is the reason why Etripamil was developed. It is a novel investigational L-type calcium channel blocker that's formulated as an intranasal spray. So you don't need intravenous access. You don't need oral bioavailability, which can be delayed to 30 to 60 minutes. It has rapid onset of action, achieving a peak plasma concentration within 7 minutes. It is short-acting because it is metabolized by blood esterases, and it's really meant to satisfy this unmet need of SVT management without needing a healthcare, being in a healthcare environment. These graphs here on the right show that after the initial peak plasma concentration within 7 minutes, as quickly tapers off. The bottom graph shows that after, based on pharmacokinetic studies, administering a second dose of drug after 10 minutes resulted in a second peak concentration of Etripamil. And this was the reason, or this was the basis for the RAPID study that was published last year. The RAPID trial wanted to evaluate patients who had SVT and randomize them to either Etripamil or placebo. Patients were given a ECG patch at the onset of SVT that they self-applied, performed a vagal maneuver, and if that was ineffective, they either gave themselves Etripamil or placebo. And the termination was assessed at 30 minutes, showing that 64% of patients receiving Etripamil terminating SVT compared to 31% with control, which equates to a hazard ratio of 2.62. And at 60 minutes, 73.5% of patients with Etripamil converted compared to 54% with placebo. At the end of 300 minutes, 82.7% converted with Etripamil compared to 72% with placebo. The median time to conversion with Etripamil was 17.2 minutes, which was 3 times faster than that of placebo. And the safety analysis found that there were no episodes of third degree or second degree AV block following administration of Etripamil. Adverse events were mostly related to the drug's nasal route administration. It is an acidic solution, so patients could experience nasal discomfort or congestion, which was, or epistaxis, which was temporary. But most importantly, unlike the pill in the pocket oral doses that we saw, there were no episodes of syncope or pre-syncope in those given etripamil. The prior studies of Node 301, which was a single dose drug, not the second dose given at 10 minutes, showed that the efficacy was also high at 53.7% with etripamil compared to 34.7% with placebo. Node 302 was an open label etripamil trial looking at patients who could self-treat themselves with etripamil, showed that there was 60.2% conversion at 30 minutes and 75.1% at 60 minutes. And then when we recently published our Node 303 study, which was an open label of this optional 2-dose regimen of etripamil, it didn't work. He had a second dose at 10 minutes and found conversion rates were 60% at 30 minutes and 70% at 1 hour. The median time conversion was 17 minutes. This again is very consistent across multiple studies showing that etripamil can be effective in terminating SVT with very good safety profile.
Thank you. That's very interesting. So going back to our patient, he was set up for outpatient follow-up with cardiology. During that time, he didn't have any additional palpitations between his visit to the cardiologist and being seen in the emergency room. He had a normal physical exam, normal vital signs, and a normal EKG, very similar to what you saw in the beginning, and had no evidence of pre-excitation on his baseline EKG, which is something we look for when we're concerned about people with possible WPW. So we discussed different treatment options with him. Next slide. And to talk about these long-term treatments, we're going to have you listen a little bit with Dr. Knight, who's going to talk about our long-term treatment options.
Great, thank you very much. So just to briefly summarize, you presented an interesting case of a relatively young man with recurrent, now documented episodes of sustained supraventricular tachycardia that was shown on an EKG to be a regular narrow complex tachycardia. And I want to differentiate this case from 2 other scenarios. One very low risk, which would be what we commonly see in patients who are found to have what's called SVT on a monitor. So a lot of patients are now wearing long-term patch monitors, 2-week Zeo patches, for example, or Holter monitors. And it's very common to have 3 or 4 beats of what's probably an atrial tachycardia. This would get highlighted sometimes on the monitor report, and the patient sometimes will then carry a diagnosis of having SVT. So I think it's important to differentiate these patients who have, it's probably not clinically meaningful, short episodes of atrial tachycardia, which are very common on Holter monitors, compared to this patient who had to come to the emergency room for a sustained episode of SVT. And then on the opposite extreme are patients who, unlike this patient, have ventricular pre-excitation and have Wolff-Parkinson-White syndrome. And we'll talk about the different treatment options for that and considerations. But it's important to know that when patients have symptomatic WPW, that's a very urgent situation, and those patients should be rapidly evaluated or quickly evaluated by an electrophysiologist. But for the purposes of this case presentation, this particular patient, I would see this patient in the office and give them him or her 3 main options. One is continued observation. Number 2 would be medical therapy, usually daily medical therapy rather than kind of a pill in the pocket option, or catheter ablation. And I tell them this is not cancer, you're not going to die from this. And so you really have these 3 options, and every patient has a different threshold for undergoing a procedure. Some people are good candidates, some people are not good candidates. For patients who have infrequent episodes that are brief, and the patient prefers just to kind of watch and wait, I think continued observation is important. And as Dr. Ip showed, there are vagal maneuvers that patients can be taught to try to prevent sustained episodes and having to go to the emergency department. Medical therapy is low risk, relatively inexpensive with a beta blocker or a calcium channel blocker. They could, if their episodes are very infrequent, I would say, once or twice a year, they could take a pill in the pocket approach. But for patients with recurrent episodes, and you're trying to prevent episodes rather than terminate them, they can take a daily beta blocker, typically 25, 50 milligrams a day of metoprolol is a good option that we commonly start with. If a patient may have asthma or some other contraindication to beta blockers, then diltiazem or verapamil. Verapamil has been around for years. It's very effective. It's a strong AV nodal blocker, but I think most people are more comfortable prescribing diltiazem. Very rarely would we prescribe a class 1C or class 3 antiarrhythmic drugs such as flecainide, propafenone, sotalol, dofetilide for patients with SVT. Those tend to be reserved for patients with atrial fibrillation or atrial tachycardias that are not amenable to ablation. A catheter ablation procedure, I tell them, is a more definitive procedure, but it's invasive and has risks. And we'll talk about this, but in general, there's a risk of about 2 to 3% of a major complication for an invasive EP procedure. Most of them are mechanically related to placing the catheters in the groin or up into the heart. So vascular complications such as a hematoma, pericardial effusion, or pericardial tamponade. And then because the most common type of SVT we'll talk about is AV nodal reentry, which is very close to the AV node, there's a small, hopefully much less than 1% risk of heart block requiring a pacemaker. So I give them these three options. Some people are very adamant they don't want a procedure. Some patients are adamant they never want to have this again. I'd say my threshold for recommending an ablation strongly is in a patient like this. Once you've had to seek medical attention and go to the hospital, it's very disruptive, and I usually strongly encourage them to consider an ablation procedure. The guidelines do provide recommendations, which are kind of consistent with what we just talked about. This is the guideline flow diagram for regular supraventricular tachycardia. And again, the first step is to determine if there's pre-excitation, because if they have pre-excitation, they shouldn't be given those three options that we just discussed. They should be strongly encouraged, if they're eligible, to undergo an ablation procedure. And the reason is that their SVT could degenerate into atrial fibrillation. And then once they're in atrial fibrillation, it can have very rapid, frequent conduction over the accessory pathway, which can lead to a cardiac arrest, ventricular fibrillation. If the patient does not have pre-excitation, then ablation should be offered to the patient, but they should be considered for medical therapy or catheter ablation. An ablation is still a class 1 recommendation for a patient who prefers an ablation procedure for SVT. And then again, if the patient wants a medical option, the beta blockers and calcium channel blockers in the absence of pre-excitation are a class 1 recommendation. The other are much less commonly prescribed. Now, most of the time we see a patient like was presented and we have a regular narrow complex tachycardia, and we can come up with clues if they're not pre-excited as to whether they have AV nodal reentry or AV reentry with an accessory pathway. There are generally 3 categories of SVT. The most common is AV nodal reentry, and it appears on an EKG as the P wave is within the QRS and not visible, or at the tail end of the QRS. So there's simultaneous activation of the atrium and ventricle, so in series or in parallel rather than in series. When a patient has an accessory pathway and they have AV reentry, it goes over the AV node and up the accessory pathway, and it takes a while. So the P wave is further out, and the P wave is more visible beyond the QRS. If you can be confident in making the diagnosis on the EKG, then this is kind of a reasonable workflow, which is the same as we just talked about. Is, you know, if a patient prefers an ablation, they can have an ablation procedure versus antiarrhythmic drug therapy. If for some reason it's been diagnosed, or you're really confident they have orthodromic AV reentry, which is very likely if someone has pre-excitation, then again, if they have pre-excitation, it's a class 1 recommendation to consider an ablation. It's not recommended that they be treated with beta blockers or calcium channel blockers. In the absence of pre-excitation, the patient can be offered either. So maybe we can go back to the case presentation and what was offered to the patient.
You're on mute, Dr. Dye.
Thank you. Thank you, Dr. Knight. After discussing with the cardiologist, he wanted to have a referral to EP for catheter ablation. So while waiting for an appointment, we do a typical workup to make sure the patient has a structurally normal heart. He had an echocardiogram, which was normal with no structural abnormalities. He did have an episode of palpitations while waiting. And he was able to catch this on his Apple Watch, but oddly enough, it told me it was atrial fibrillation. So he came in, also brought those patients of those tracings as well. He met with the electrophysiologist, so he met with me, and we discussed risk and benefits. After a discussion with the patient, it was decided that we were going to proceed with the catheter ablation.
Thank you. So I'm going to stick with his SVT diagnosis. You mentioned that he had an Apple Watch alert for AFib. It's important to look at those strips very carefully because there are often false positive diagnoses by these wearable devices for atrial fibrillation. But just to recap, the class 1 indications for catheter ablation in patients with a regular narrow complex tachycardia are symptomatic Wolff-Parkinson-White syndrome, mainly for the reasons we described, because there is a small risk of sudden death. The risk of dying from an ablation procedure in someone with WPW is lower than the risk of not performing the procedure. PSVT that requires hospitalization or is poorly tolerated, or I would include a trip to the emergency department, as was the case presented. It's refractory to drug therapy. So I discussed kind of the medical therapy versus ablation option, but when patients have taken maximally tolerated antiarrhythmic drugs or beta blockers, and they continue to have episodes, they're a good candidate for an ablation, or if it's just a patient preference. So this is a slide from the guidelines, but again, I would focus on the 3 categories of SVT, which include AV nodal reentry, AV reentry with an accessory pathway, and a focal atrial tachycardia. The atrial flutters that are listed on here are usually distinguished and put in a category of other atrial arrhythmias and atrial fibrillation. The management of atrial flutter still includes medical therapy or catheter ablation, but I'm going to focus on AV nodal reentry, which accounts for probably at least 2/3 of cases of SVT in patients brought to the EP laboratory. And we'll talk about how we ablate these, but the first step is to undergo an electrophysiology diagnostic part of the procedure. So for those who are listening who are not familiar with what we do in the EP lab, the patients lay, and what I tell patients in the office is that they lay on an X-ray table for about 2 to 3 hours. We place at least 3 femoral venous sheaths and place those up into the heart in different chambers, usually the right atrium, the right ventricle, the His position, and often the coronary sinus. So we start in the right heart. These are usually done with fluoroscopy and X-ray, although we have advanced mapping systems that minimize X-ray and in some cases eliminate the need for fluoroscopy. The next step is to perform an EP study, where we look at the substrate that we find, whether the patient has a concealed accessory pathway, so they don't have ventricular pre-excitation, but they have an accessory pathway that we can detect. And then we induce the arrhythmia and make a diagnosis. Once we've established the diagnosis, then we identify the target. So for AV nodal reentry, we target the slow pathway, and we'll show examples of that. Or an accessory pathway, we target the accessory pathway. And for a focal atrial tachycardia, we have to be able to induce it and find it and so-called map it and ablate it. The success rate for all of these arrhythmias is over 95%. The rate of a major complication is about 2 to 3%. And the likelihood of recurrence in this slide from 2015 for AV nodal reentry is 5%, for an accessory pathway is 8%, and for an atrial tachycardia, much higher. I would argue that these are, in experienced labs, much higher than we see. I tell patients in the office that if they have an AV nodal dependent SVT, such as AV nodal reentry or AV reentry due to a concealed accessory pathway, the success rate's over 95%, and that the likelihood of a recurrence is probably about 1 to 2%, and the risk of a major complication is about 2 to 3%. So just historically, it's important to talk about how long this has been going on. Mel Scheinman and my former mentor at University of Michigan, Fred Marotti, described catheter-induced ablation of the AV junction to control refractory SVTs in 1982. Now, this is before they used radio frequency. They were using DC shocks. They were delivering shocks within the heart that led to necrosis of the target but were risky procedures, and in some cases were associated with barotrauma and cardiac perforation. Then this was used for Wolff-Parkinson-White syndrome to ablate an accessory pathway. In the late 80s and early 90s, the next energy source was radiofrequency. So as a medicine trainee at the University of Michigan in the early 90s, I can recall all these patients undergoing radiofrequency ablation of SVT, and it was a really big deal. They all had to have troponins measured and CKs measured, cardiac echoes performed before they could go home. It's now a routine procedure, same-day discharge, and a very safe procedure. So if we trigger AV nodal reentry, the reentrant circuit involves two approaches to the AV node. And as seen on this slide, the slow pathway is one approach to the AV node. It's depicted by the star. The fast pathway is the other approach to the AV node. And a premature atrial beat can come down and encounter both of these pathways and block in the fast pathway, go over the slow pathway and find the fast pathways recovered because of slow conduction. And it can set up a reentrant circuit in this triangle here referred to as the triangle of Koch. The slow pathway is the tissue between the coronary sinus ostium, which is that opening seen in that triangle just above the number 2, and the tricuspid leaflet, which is seen right where the word slow is. And we place a catheter from the femoral vein up across into the right atrium, and we target this spot with radiofrequency right outside the coronary sinus ostium. An accessory pathway is a hair-like structure. It's a bridge of atrial myocardium from the atrium to the ventricle. And you can see the arrow points to a histological example of a muscle fiber connecting the atrium to the ventricle. And that asterisk is where we ablate from. To the far right are coronary arteries and coronary veins. So when we're on the inside of the heart, we can either come on the atrial side or the ventricular side, or just underneath the valve where that asterisk is, and deliver a radiofrequency lesion, which is radiofrequency energy that leads to heating of the tissue and necrosis and creates about a 4 millimeter pea-like size ablation lesion that should be permanent if we're able to deliver a long enough lesion, and eliminates the accessory pathway. Well, what do we have to think about when we ablate these hair-like accessory pathways? One is, how do we get to them? Right-sided accessory pathways that connect the right atrium, the right ventricle, cross the tricuspid annulus. Left-sided accessory pathways cross the mitral annulus. So from the femoral vein, we can reach right-sided structures. To get to the left side, we used to routinely go retrograde to get femoral arterial access and take a retrograde aortic approach. With our experience now with transseptal catheterization, with better tools and with all the experience with AFib ablation, most left-sided accessory pathways are ablated using a transseptal approach. We have to find the accessory pathway, so we can do this with two different types of catheters. We can do this with the ablation catheter. We now have tools which are ultra-high density mapping catheters that we can position in different chambers to find the accessory pathway. But where is the pathway? Well, if the patient's pre-excited, it connects from the atrium to the ventricle, and we can find the spot where the ventricle is activated the soonest. When a patient has a concealed accessory pathway that just goes retrograde, we can pace the ventricle, or during tachycardia, find the site of earliest atrial activation using these mapping techniques that rely on timing. There are also pathway site-specific considerations, and we'll go through a little bit of this, but it's important, even when you see a patient in clinic and you think you know where the accessory pathway might be because they're pre-excited, you need to let them know that this is a pathway that could be very close to the AV node and at risk for a heart block. Again, I think that in modern day, highly experienced labs, the success rate for ablation for an accessory pathway is well over 95%, and the complications for a major complication are about 2 to 3%. There are reasons for difficult ablations, particularly patients who have had failed ablations elsewhere. It can be related to the ability to get to the spot. There are some pathways that are truly epicardial and you can't get to them from inside the heart. And there are some pathways which are too close to critical structures, such as the coronary arteries, or more commonly the conduction system. I'll go back and hear a little bit more about what was found during the EP study.
All right, thank you, Dr. Knight. So this patient did have an EP study performed. During the EP study, oddly enough, the patient did actually go into atrial fluid and atrial fibrillation. This wasn't too unexpected because, as Dr. Knight said, we did take a look at the tracing, and although not always accurate, the Apple Watch was kind of accurate at that time. Ultimately, after the patient was pushed back into sinus rhythm, we found that the patient had AVRT and had a concealed left-sided biseptal accessory pathway. Because the patient also had the atrial flutter, and the atrial flutter while he was in it was matched and trained, it was consistent with what we consider to be a typical atrial flutter, we took care of it that time. However, the patient only went into the atrial fibrillation in the setting of him also having the AVRT. So at that time, we did see no reason to do anything like a pulmonary vein isolation, or thought that the patient required any medications for the atrial fibrillation, because it was thought to be more associated with the accessory pathway and just the pace of it, and not necessarily him having pulmonary veins as a trigger for his atrial fibrillation. Next slide. Now we're going to talk about. Oh.
No, I was just going to summarize what you said. I think that was useful. It's important to know that when patients have an accessory pathway and they develop an arrhythmia, the re-entrant arrhythmia involving the pathway, it can degenerate into atrial fibrillation, particularly in a young patient like this. It's been well reported that the outcomes of a successful ablation procedure make the likelihood of recurrent atrial fibrillation very, very low. So it would not be appropriate to do a, quote, AFib ablation in this patient, as you guys rightly focused on the pathway itself. So we talked a little bit about AV nodal reentry and accessory pathway ablations, because this patient had an accessory pathway. I'm going to talk a little bit more about site-specific considerations. So in this figure, which I'll show a few times, you can see this kind of what we call owl's eye appearance. So when we're looking from kind of the left anterior oblique view with fluoroscopy, we see this kind of two circles. There's the tricuspid valve and the mitral valve, and the coronary sinus going underneath the mitral annulus. And the accessory pathways connect the atrium to the ventricle. They can be divided into septal accessory pathways, right free wall pathways, and left free wall pathways. There are very few, if any, accessory pathways up by the aortic valve. So the free wall pathways are kind of anterior, lateral, and posterior. The right free wall pathways are anterior, lateral, and posterior. And then there's anteroseptal, midseptal, and postseptal pathways. So if we identify that this patient has ventricular pre-excitation or a concealed accessory pathway connecting the right atrium to the right ventricle, then we navigate one of the ablation catheters over there. The challenges with these accessory pathways is catheter stability. So we now have deflectable sheaths, steerable sheaths, and much better tools. We can measure contact force so that we know we're in a good, stable contact before we deliver radio frequency. So our ability to tackle these right free wall pathways has improved significantly. Left free wall pathways are the most common. The most common way to get there, as I discussed, is transseptal catheterization, which has become a very safe, almost routine procedure now. And we map the area between what we would call kind of 1 o'clock in the mitral annulus down to about 6 o'clock in the mitral annulus to find the site where we would ablate. Other pathways can be right-sided, but close to the His bundle. And there has to be great care in ablating these to avoid heart block. And it's become increasingly recognized that some of these can be ablated not from the right side of the heart near the tricuspid annulus, but actually from within the aortic root. So we can go from the femoral artery up into the aortic root, and in the aortic cusps, we can ablate these without causing heart block. If they're coming from the AV node, we can't record a His bundle signal, so it even becomes a little bit more risky of getting heart block. So we have to be extra diligent about how we do that. There are many techniques that we use. There are cases where the risk of heart block is too high to warrant ablation of the pathway. There are other tools that can be used, including cryoenergy, to lower the risk of heart block, and it gives you a little bit more reversibility of the early lesion, so you can come off if you're getting heart block. Probably the most challenging locations are those in the posteroseptal space, because they can be right-sided or left-sided, or they can involve the coronary sinus musculature. We call that kind of a posterior pyramidal space. And we often map within the coronary sinus on the right side, go transseptal, and map on the left side before we find the appropriate target. So this is from a publication mostly from Hugh Calkins in the early 90s for how to map the accessory pathway. If a patient has antegrade conduction, meaning they're pre-excited and they have Wolff-Parkinson-White syndrome, you can find a recording from the accessory pathway. So you see an electrogram from the atrium, you see an electrogram from the ventricle, and in between you see a very sharp potential that's actually coming from the accessory pathway. That's ideal, but that's often not achievable. And so what we often do is find the earliest ventricular recording relative to the delta wave, and very good electrogram stability, knowing that you're in good contact. A good atrial signal, a good ventricular signal, it's a clue that you're right on the annulus of either the mitral or tricuspid annulus. If there's only retrograde conduction, if they have a concealed accessory pathway, you might also find an accessory pathway potential, or a Kent potential, some people refer to it as. But what we're looking for usually is continuous electrical activity during orthodromic reentrant tachycardia or ventricular pacing if it's far from the AV node, with good catheter stability. These were criteria that were used in the early days of mapping with the ablation catheter. We now have high-density mapping catheters and what we call ultra-high-density mapping catheters, whether they're in the shape of a pentaray or a spline with multiple electrodes on them, or kind of a flat fly swatter grid-type electrograms. You can get very high-quality maps, very high-density maps, and use that to target. You can also use specifically what's called open window mapping, as shown here in this video. You can not just look at the ventricle during activation or the atrium during activation, you look at both, and it's kind of referred to as open mapping. And in the next slide, you can kind of see both the electrograms and the open map. So the horizontal, in the upper half of this image or this video, you see a blue or kind of aqua colored multi-electrode catheter. That is the coronary sinus catheter that's displayed. The green arrow is coming from the tip of an ablation catheter, and those small colored spheres that are pink represent either ablation lesions or areas of interest. And you can see that the map allowed identification of the earliest activation of the accessory pathway. And so on the bottom half of this video that's being played are the intracardiac electrograms. The ones that are in that blue color come from the coronary sinus, and the ones that are from the red color come from the ablation catheter, either the distal or proximal pairs. So again, what we're looking for during the tachycardia is, where is the atrium activated first? That's where the accessory pathway inserts and starts activation of the accessory pathway. So using high-density mapping as well as conventional mapping, this accessory pathway was successfully ablated. This is again from an early publication that Fred Marotti, when he put together a large series, I think over 200 patients who had an accessory pathway ablated, what were the complications? And I think this is consistent with what I've said so far. There's a very small risk of vascular and cardiac mechanical complications, such as pericardial effusion. In this series, it was 0.5%, and heart block was 0.5%. The other complications are very low. We do these with, aseptic techniques, but the risk of bacteremia or infection is very, very low. Most of the risks are related to mechanical complications or related to injury to the conduction system. And I think I'll stop there. I think Dr. Dye is going to come on and continue the case. Thank you.
Thank you. So as seen, we performed the ablation of the AVRT. As discussed before, we didn't do anything in regards to atrial fibrillation. The atrial flutter occurred before and after the accessory pathway was gone, and so it was thought that the patient, although young, still must have had substrate for atrial flutter. So a simple CTI line was performed with bidirectional block. After that, no further ablation or medication. The patient did really well. He didn't have any recurrence of his symptoms, didn't have any kind of issues. So even in follow-up and on recurrent, and has been doing well and exercising as he's needed to. Next slide. So we've noticed that some people have put some questions in our Q&A. So we'll ask Dr. Knight and Dr. Eve to answer some of these questions. And if time allows, we'll talk about some discussion points as well. So for our first question, it says, why would pill in the pocket side effects be different / more ineffective compared to being on a daily beta blocker?
Sure, I think that the decision to, well, I suppose I reviewed the data behind pill in the pocket. I think a lot of cardiologists and electrophysiologists do offer this as a approach for, especially for patients who have very infrequent episodes of SVT. Though after having reviewed the data and looking at it, and admittedly, I'm interested in this because I've been studying the effectiveness and safety of intranasal etripamil as a comparator. But the pill in the pocket, the side effects that I think we're most concerned about is the syncope or the hypertension. It's basically uncontrolled. Every patient is different in how much they're going to respond. Whether they'll terminate with SVT, and when they do terminate with SVT, will that drive their blood pressure temporarily lower and their heart rate slower during the time of conversion. It was very interesting that during the studies of etripamil, when patients were given the drug to terminate their SVT, we want to look for any pauses, conversion pauses. As you know, when we give adenosine, you can see a significant and prolonged or temporary cessation of sinus rhythm or AV block that then returns. Interestingly, with this etripamil, there were no pauses that were prolonged after termination.
For our other question, what about people who have multiple occurrences of short bursts of SVT rather than sustained? Is treatment any different?
Well, I can talk about ablation as an option, but it depends. If you think there are multiple occurrences of short bursts of SVT or atrial tachycardia, which is by far the most common source of these frequent short episodes of SVT, sometimes just reassurance is all that's necessary. They don't necessarily have to be treated. If there are short episodes of atrial tachycardia, it would be very rare that we would recommend or offer an ablation procedure. And the reason is that we have to be able to trigger atrial tachycardias and map them if we're going to successfully ablate them. So probably once a week, I see a patient who has 5 to 10 beats of SVT on their monitor. It's frequent, and I have to tell them that an ablation option really is not a feasible option. If they're having it every 30 seconds, then yes, it could be coming from the pulmonary vein or somewhere that you can map if it's frequent enough. But if it's every hour or so, that's not realistic. So in those cases, it really can be some reassurance that they just don't have a real sustained SVT problem, or a beta blocker, a calcium channel blocker. So your goal is to improve symptoms, and if they're highly symptomatic, I think you should offer them something.
Yeah, I would echo that. I definitely agree with Dr. Knight on that. A lot of them, they have these short bursts. Fortunately, now with the rising use of wearables, Apple Watches, cardio devices, they can capture these very short bursts of SVT, which oftentimes turns out being some pulmonary atrial tachycardia, which could eventually be related to pulmonary firing. Antiarrhythmic, if beta blockers or calcium channel blockers are not effective for chronic use, then using a class 1C medication like flecainide or propafenone, which can be used for paroxysmal AFib, can be effective for people with PAT.
Thank you. Slightly off topic, but there was a question asking, how do we treat symptomatic inappropriate tachycardia in acute settings?
I'll let Dr. Ip answer that question.
I'd say inappropriate tachycardia. I suppose that maybe they're talking about, well, there's inappropriate tachycardia, which oftentimes can be a pathologic condition like paroxysmal supraventricular tachycardia. The word inappropriate, sometimes people use it to describe inappropriate sinus tachycardia, which would be a whole other different discussion about patients who have basically any symptoms related to tachycardia. Would be essential to figure out the diagnosis. If patients have a wearable, that's when we have recordings, as opposed to just chalking up to some anxiety. I think a lot of patients, that's another thing that to keep in mind, that many patients are undiagnosed from their SVT because of lack of evidence or recordings. And if they can get themselves to get an EKG or obtain one of these wearable devices, we can surely delineate where the P waves are in relation to the QRS complexes and determine if it is truly sinus tachycardia or an paroxysmal supraventricular tachycardia, TSVT.
Yeah, I would just add to that, if someone has what looks like sinus tachycardia, acutely the focus really should be on what's driving it. Acutely, there should be a very diligent search for any underlying cause. Most of these people have some underlying cause, whether it's other anti-cholinergic medications, psychiatric medications, anxiety, anemia, fever, something else like that. But it's important, excuse me, to differentiate sinus tachycardia from atrial tachycardia, because there are some patients who have a true sustained atrial tachycardia that can be treated with an ablation. But most of these patients don't require any acute therapy.
We have another question coming through. How important is it to control tachycardia / SVT with cardiomyopathy?
That's a great question. And there's a couple of other sub-questions or answers related to that, in that some people, they can develop a tachycardia-induced cardiomyopathy. Just as Dr. Knight described, some patients have some sort of atrial tachycardia that can be misdiagnosed as sinus tachycardia. They may even be picked up incidentally. Patients have prolonged periods of tachycardia, which can then lead to a stress on the heart and a cardiomyopathy. And once you treat the focal atrial tachycardia, then their cardiomyopathy resolves. And so those are great cases. I've certainly seen a number of those. Patients have the 12-lead EKG, and there's a slight variation in the P wave compared to when their heart rate is slower in sinus rhythm, and turns out they actually have a focal cardiomyopathy. Now, there are patients who have a cardiomyopathy from a primary etiology, and they develop a tachycardia that may be secondary. So whether it be sinus tachycardia from compensating from their decreased stroke volume, that's sort of a different category altogether.
Yeah, there's some clues I think that are helpful. If someone has a resting heart rate of 110 or 120 and has a cardiomyopathy, a dilated cardiomyopathy and heart failure, it's important to look very carefully at the P wave morphology, because if it's not sinus-like, it's much more likely they have an atrial tachycardia. Number two, if you see on the monitor that they're having episodes of AV block, that's much more likely an atrial tachycardia, because if it's sinus tachycardia due to elevated sympathetic tone, they're going to have one-to-one conduction the whole time. If they have AV block, especially when they're sleeping, well, at any time, it's kind of like pacing the atrium. And then, the faster it is, the more likely it's probably not sinus tachycardia.
Some diagnostic maneuvers, a vagal maneuver, or use of adenosine can cause some sort of either interruption or cessation or temporary suppression or termination of the tachycardia and distinguish it from sinus rhythm.
But even atrial tachycardias you might think that if it was a fixed heart rate, like if it's always a fixed heart rate, that would be likely to be an atrial tachycardia. That's probably true. But the opposite's not true. The atrial tachycardia rates can vary with sympathetic tone as well.
Yes, definitely. Focal automatics, those are the harder ones.
All right. And then we have another question. How often are you able to determine the root causes for SVT or other arrhythmias? Have you seen these root causes once resolved cure the SVT?
I can take that since it's kind of related to ablation. It's when someone has a reentrant supraventricular tachycardia that comes on suddenly and terminates suddenly, and it's been documented on a 12-lead EKG. Those are usually because they have substrate for it. They have an accessory pathway, or they have a slow pathway. And the question is then, why aren't they constantly in the rhythm, right? It's because a premature atrial beat can trigger it, and then a premature atrial beat can terminate it. And so there are situations where they have much more SVT than usual, possibly because they have more ectopy, and the sympathetic tone is just right. The conditions are just right. But in general, these secondary causes like anemia, they don't cause SVT in patients unless they also have that substrate. And so an ablation, eliminating that substrate, will eliminate the problem.
Yeah, that I often get that question asked by patients. Oh, well, maybe I was just stressed, or I was drinking too much caffeine, and then if I reduce my stress level or reduce my caffeine level, maybe my SVT will go away. But as Dr. Knight pointed out, they definitely have an anatomic circuit or electrophysiological circuit within their heart that is providing them the ability to sustain the arrhythmia. And it is only with ablation that becomes cured or and/or managed with medications.
Looks like that's the end of our open questions. Did anyone of you gentlemen have any comments before we come to our close?
No, I would just say to the listeners, if you are thinking about referring a patient for an ablation, experience does matter. You've got 3 outstanding, well, at least 2 other outstanding EPs on the, excluding my colleagues. So I think it's important, my point is to refer patients to a center that has a lot of experience if you want to get a good outcome for an ablation procedure.
All right, well, thank you, gentlemen. As a recap, we'll go over saying that we discussed the acute contemporary treatments for SVT. We talked about acute treatments, which could be vagal maneuvers, watchful waiting, or to use as needed medications or daily medications. We also talked about long-term treatments, with the mainstay being ablation for AVNRT and AVRT, and oftentimes for atrial tachycardia. But in those cases, sometimes depending on patient preference or disease process, can use medications. Also take into account special populations that have WPW. Those are better done with ablation and try to be treated with medications. Thank you for your time. On our next slide, we have our upcoming webinars, and at that point, we'll talk a little bit more about our special populations in February 2025. For more education and to see the recording of today's webinar soon, visit learn.heart.org. And thank you.
Thank you.
Hi, thank you.